Hi, my name is Tim Rebbeck. I'm from the Zoo Family Center for Global Cancer Prevention at the Harvard T.H. Chan School of Public Health. And I'd like to spend a couple of minutes today talking to you about equity, prevention, and early detection, and the promise that the Cancer Moonshot 2.0 presents to us in this regard. So I think, as most of you know, the Cancer Moonshot has been relaunched by President Biden. Uh, and the goal of this moonshot is stated to be working together over the next 25 years. We will cut today's age-adjusted death rate from cancer by at least 50%. And we will improve the experience of people and their families living with and surviving cancer. So that's a very big goal. It's a lofty goal, but it's certainly one that's worth pursuing. Within this moonshot, 7 priorities have been identified to diagnose cancer sooner, prevent cancer, address inequities, target the right treatments to the right patients, speed progress against the most deadly and rare cancers, support patients, caregivers, and survivors, and learn from all patients. And as you can see, many of the top priorities are priorities that I think we in the prevention and early detection community are very dedicated to seeing through. And it's really encouraging to see that the Cancer Moonshot has targeted so many of the principles and goals and the vision and mission that we share. So one of the big things that the President's Cancer Panel has done in conjunction with guidance about the moonshot is to make statements about closing the gaps in cancer screening, connecting people, communities, and systems to improve equity and access. So the first thing they state is to deliver the message of urgency and increased access after COVID-19. And in part, that's because of the lag in screening and early detection that occurred during COVID-19. It's also to ensure equitable access to screening and prevention through modalities like at-home screening, screening in communities without easy access to a clinic, community health networks that the National Cancer Institute will organize, the collective efforts of NCI cancer centers, and organizing the NCI Community Oncology Research Network, or NCORP. Another goal is to develop a focus program to expeditiously study and evaluate multi-cancer detection tests. And I'm going to spend a little bit of time later talking about those because they're very promising. And finally, accelerate efforts to nearly eliminate cervical cancer through screening and HPV vaccination, especially in people who are at most risk. And again, these are goals that I think you in this audience and I certainly all share. And so it's very encouraging, again, to note that both the Moonshot and the President's Cancer Panel that is advising the Moonshot have these very important goals for eliminating cancer, the burden of cancer, through prevention and early detection. So there are 2 areas of opportunity that you can imagine. One is to expand the use of proven cancer prevention and early detection strategies. And second is to develop and evaluate novel cancer detection tests. So as you know, cancers with screening tests in use include breast, cervical, colorectal, and lung, and prostate, but which is of debatable or at least controversial value. But among these, mammogram, pap smears, colonoscopies, and lung low-dose CT screening are variably used by different groups in the population. None of the groups in the population have very high levels of usage of these proven screening tests. And so this is the first point in this recommendation, that we ensure access to current and new standards of cancer care in all populations. And there's still work to be done. And I'm not going to spend a great deal of time on this today, except to say that this is a question of implementation science. We know these programs and screening strategies work. We now need to make sure that we get them to all populations who will benefit. But of course, there are a lot of common cancers without high mortality and with high mortality and without screening tests: bladder cancer, liver, ovary, pancreas, stomach, and others. And so what are we going to do with these? Unlike the cancers on the left-hand side of this slide, The cancers on the right-hand side of this slide are associated with very high mortality, and we've worked very hard in the field to try to find screening tests, early detection tests, but without much success so far. And so I think it's really incumbent on us to think about both the cancers that are with screening tests but are not highly used, or at least optimally used by all populations, as well as those that we've been so far unsuccessful in finding screening modalities. So one of the big opportunities that lies ahead of us is that of liquid biopsy. Liquid biopsy, I'm sure you've heard of, is defined by the concept that a tumor has mutated DNA or other features that are then shed into the blood. And those molecular features can then be measured in the blood so that we can identify someone who might be harboring a tumor that is perhaps not yet identified by a standard screening tool, or for which there are no good screening strategies available. And so most of these involve genomic alterations, including epigenetics or methylation patterns, large-scale DNA damage, chromosomal aberrations, point mutations, copy number variations. Suffice it to say, there are many types of molecular signatures that are found in tumors, and then we think might be able to be found in blood and therefore used as biomarkers for early detection. So far, there are at least 25 companies that have proposed these multi-cancer detection tests, and many, many more are in the works. And the goal of these companies is, again, not to identify the presence of a single cancer, but as the multi-cancer detection name suggests, use these patterns of molecular signatures, mutated DNA that could arise from any tumor site, any anatomic site from many, many different cancers. And the goal of this and the brilliance of this is really to say we can find mutated DNA, we can find alterations, biomarkers in the blood, no matter where they're coming from. And so a simple blood test can then pick out the presence of a tumor no matter where it arose. So this is a really great concept. But as I'm going to talk to you right now, we're early in the process of developing these tests and implementing them. And so I wanted to kind of give you, without forgetting that this is an incredibly important, fascinating, scientifically interesting, and also clinically and public health relevant initiative to be undertaking. It's going to revolutionize the way we screen for cancer. But right now, we have a lot of things we need to think about. There are a number of consortia and governmental efforts underway in addition to the private sector. The NCI has launched a number of groups who are discussing liquid biopsies, the use of genomics. They're creating biobanks, and they've recently announced the Access study, which is going to be a large consortium network of institutions around the country who will study these liquid biopsy MCD tests. There are also two independent groups, including the Multi-Cancer Early Detection Consortium and BloodPAC, who are also representing industry, government, academia, and other groups to try to bring some coherence to this very rapidly developing field. So some of the challenges for early cancer detection were outlined recently in a paper by David Crosby and a larger group. So the first challenge of this area is to understand the biology and prognosis of early cancer. The second is to determine the risk of developing cancer. The third is finding and validating cancer detection biomarkers. The fourth is developing accurate technologies for early detection. And the fifth is to evaluate early detection approaches. And so these are the kinds of areas that we're facing right now that we really need to spend some time both developing and then implementing. When we think about this in the population, we also need to be really concerned about the ability that all people will benefit from these tests. So when we think about some of these challenges, we can also consider, are there racial or differences in the biology if we need to understand that biology? If we need to determine the risk, does the risk differ by race or ethnicity, or is it maybe contextual around risk factors that might differ by race? Finding and validating biomarkers. Are the biomarkers, can they be equally or equitably applied in all groups? To develop these accurate technologies, will the technologies impact on equity? And I'll come back to this point in a minute, which is an important one. And finally, how will implementation and access affect equity? These are the sorts of questions that not only do we need to build for the tests in general, we need to achieve these activities so that all people will benefit. So will these MCD tests increase or decrease compliance with standard screening? If you have a blood test, are you less likely to have your colonoscopy? That would be a problem, I think, because we know colonoscopy works. Will imaging or other companion tests be required for everyone with a positive result? Is this standalone or ancillary? So, for example, if everybody who gets a test and has some an unusual finding, will they all have to have a PET scan? Will the tests themselves always be accompanying standard things that we can already do? How does the current test combine with other modalities that we know about in screening and early detection? Is there a role for genetic counselors? So who's going to provide the interpretation of these results? Is it a genetic counselor or is it someone else maybe? Genetic counselors are currently overloaded with people who are interested in germline genetics and risk assessment and things like that. But somebody has to be there, a genetic counselor type person has to be there to interpret these tests, talk to people about making decisions. And particularly if these tests get widely used, that's going to be an overwhelming burden for the healthcare workforce. So we need to think about that. Who are we going to test? Are we going to test everybody? In some settings, you can imagine a multi-cancer test that anybody can get at a Walmart or a CVS, not even having to go to the doctor. That would be a wonderful thing. But if everybody has one of these tests and millions of people are having these tests, how do we handle that with a healthcare system that we have right now? Who's going to get follow-up? Is that follow-up going to be timely? Or should we really focus on people that are very high risk, the ones that are most likely to develop cancer? Should we find people who are asymptomatic versus symptomatic? So maybe if you start having some diffuse symptoms, maybe you have one of these tests to see are your symptoms associated with cancer, and can it be found by this test? What happens if you're having indeterminate clinical or imaging findings? So maybe there's something going on in a workup and you're not sure if you have cancer. Maybe these tests can be used to help decide if there's a tumor there. So there's a lot of questions about who will even apply these tests in. And what's the potential for overdiagnosis? We know that there are a lot of cancers out there that may not need to be diagnosed or treated. We certainly have had this experience in prostate cancer with PSA screening, but you can think there are potentially thyroid cancers or other indolent cancers out there that really may not require treatment. And what is the implication if we start finding positives in people that may not benefit from treatment? More questions. How is this, our results going to be interpreted? Are we going to be doing this really for lots and lots of cancers? How will we figure out what cancer? Many of these tests don't tell you where the tumor came from. They just tell you there's mutated DNA in your blood. So you have to then go through and figure out, if there's a tumor there, where is it coming from? And how are we going to do that? Are we going to interpret these tests by cancer type, or are we going to do it overall? What about, should we focus on cancers without screening options? That makes a lot of sense. I don't know that we need another test for lung cancer or colonoscopy for colon cancer. But as I said earlier, not everybody uses those tests. And so maybe it will be helpful for us to get people who are avoiding or not able to have a colonoscopy or a low-dose CT screen. Maybe those people can benefit from having some of these easier blood tests. And then to ensure that we, use the known test in conjunction, as I said before, with these novel tests. So those are questions. What endpoints are we looking for? Are we looking for reduction in mortality. That's the gold standard, but it'll be very hard to do that. Obviously, the clinical trials, the research that needs to be done is going to take years, if not decades, if we're starting to detect cancers very early until we can really make a statement about reduction in mortality. Is it good enough to say we're going to stage shift? We're going to start finding tumors earlier? We know from other studies that finding tumors earlier is really important, but the stage shift itself might not impact on mortality in everybody. Maybe we just need to think about reduction in distant metastases or improved quality of life. Really, what endpoints we're going to be able to study and then make inferences about from these tests are still really to be under discussion. Will MCED tests define a new class of high risk based on the test results themselves? That is, what if you start finding a few molecules that are a little bit off, and maybe it's not quite enough to do a diagnostic workup, but maybe it is, and you don't find something? Is this a new group of high risk people that need a different kind of follow-up, that need a different kind of support? Because as I said, there are plenty of false positives, at least in the current tests that we see, that might suggest that they are actually at high risk, even though we can't find the tumor. And we haven't defined that yet. We really don't know what those false positives might mean. Is it just a bad test, or is it in fact something's really going on, and those people are at high risk and we need to do something with them? We also need to think about cost effectiveness. So the Hackshaw recently estimated that there's a 2.5 times cost of MCDs versus other tests, but a substantial 12-fold increase in detection of cancers. So, but we really don't know yet. These tests right now, the one test that is on the market costs $940, and it's not reimbursed. It's, you write a check for it if you want to get it. And it's one of the, and so not everybody's going to be able to do that test, even though, you know, it's very early and we still don't know how to manage these. But the tests are going to cost something. Will they be reimbursed by insurance? How will they be handled? And is it cost effective the way they're being developed and rolled out? So finally, let me just say a couple things about equity. So will these multi-cancer detection tests improve accessibility or impact on only select population? Will they widen disparities, particularly because they're going to be downstream workup and diagnostic requirements that everyone doesn't have the equal access to? So I'm just going to give you the example of mammography. So this is a data that came out this past year. Everyone's very familiar with mammography. And the fact that it's a wonderful tool. It has saved many lives. It's something that is of incredible value. We also have learned that adjuvant endocrine therapy, the treatment of hormone receptor positive or negative positive tumors, had great value in so things like tamoxifen or other hormonal therapies. But if you look at this plot, what I'm showing you is that before 1980, Black women had really better mortality statistics. They died less frequently than white women. It was about equal, but Black and white women at minimum had about the same mortality rate. After the advent of mammography and adjuvant endocrine therapies, those curves started separating. And now, as you know, today, Black women have a substantially higher probability of death from breast cancer than white women. And I'm not saying that mammography and adjuvant endocrine therapy are the only culprits in this, but they certainly contributed to the disparity. And it's because access was not equitable. There are biological differences in the tumors of Black women who have more estrogen receptor negative cancers and therefore are not going to benefit from adjuvant endocrine therapies. And so there are differences that lead to this. And so I think it's really important as we begin to develop new technologies that are going to be wonderful, that we also ensure that everyone will benefit. And now's the time, particularly with these multi-cancer detection tests, that we develop them with an eye toward equitable data, equitable baseline test characteristics, but then also equitable access and implementation. So equity and benefit means that equally applied interventions only work if everybody's the same. And I think many of you, and not, people aren't the same. We know that. Everyone is different with respect to their risk and their needs and their access and other things. So I think many of you have seen this side that if we provide equal access or equal interventions, some people will benefit and others won't. So what we want to provide is equitable benefits. That is, people who need more or need more intervention, different interventions will get it. So the goal is equity in outcomes, but not equality of interventions. And I think it's really also important because there's a community input, a community take on this that has to be thought of. And that is, here we have people that are trying to watch a baseball game, and we're trying to find them a way for them to watch a baseball game. But we really also need to figure out who likes baseball. I live in Boston, and if you, I know there are a lot of people who would not want to support the Yankees, and so some people don't even like baseball. Hard to imagine, but there it is. And I think that it's really important when you're talking about developing these tests, what are the needs of particular communities? What are they looking for? What are they going to benefit from? How can we help them? And we need to figure out from them what the equitable interventions are and how they should be applied. And so this is just my point in saying the community, the end user, has to be engaged in this conversation and the tools that we develop. So just to end, to avoid creating or exacerbating disparities with new tools like these multi-cancer detection tests, we need diversity in the evidence and the development of the implementation. We need to ensure that access and cost and insurance and medicalization of tests is appropriate. It would be great, for example, if it was possible to get tests outside of a medical care setting. That might be really beneficial for a lot of access, but it may have some downsides depending on how that test needs to be followed up and if people don't get appropriate follow-up. And finally, the technology needs to be acceptable to communities that are going to use it. It needs to be usable within the systems that they live. And so just to say, there are a number of features that we need to consider as we develop these new tests to make sure they have downstream impact and benefit to everyone equitably, and we don't create or exacerbate disparities based around this new technology. So let me just end by thanking you for listening, and I appreciate your hard work and dedication toward ending cancer as we know it.